Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Welcome to the Senior Rehab Podcast. On the show today, we have Dr. Mark Cucuzzella. Dr. Mark, as many people know him, is a physician in the Eastern Panhandle of West Virginia. He's a competitive runner and a shoe store owner, which I know sounds kind of odd, physician and shoe store owner. But the shoe store has been an avenue for him to make a huge impact in his community. And today on this episode, we talk about, his story, his career, how he's used a shoe store to get people moving, to get people healthy, to get people well, and how that's really grown into a movement that goes way beyond shoes, but more into nutrition and disease reversal. So this is a very applicable conversation for many of you because most of the people that we are working with suffer from some type of metabolic condition. A lot of people have diabetes, or a lot of people are on the verge of getting that diagnosis. And Dr. Mark's message is a very, very powerful one for the patients, but then also for us as well. He has definitely shown me how to live a healthy life, to feel better, to move better. And I'm really thankful for him sharing that with me. So I wanted you all to meet him as well. So without further ado, Dr. Mark Cucuzzella. Dr. Mark Cucuzzella, welcome to the Senior Rehab Podcast. Thanks for your time.
Dustin, it's a privilege to be here.
Yes. So I don't remember if I ever told you this story, but the way I came across you was I was living in Lexington, Kentucky, and there's a shoe store there. I believe it's a John's Run Walk Shop. And I was just in the store, just looking around, didn't really want to buy anything. And I'm leaving, and I look at this blue book on the countertop, and it was called Natural Running by Danny Abshire. And I'm just flipping through the pages and the foreword and saw that you wrote a little blurb. And I just started reading it and saw your name. I didn't know how to pronounce it. And then I saw that you were an associate professor of medicine at WVU. And I mentioned that to Megan, my wife, who went to WVU for medical school, and she never heard of you. But then, we moved out to Shepherdstown and looked you up, and then we connected and started working for you, and the rest is history. But yeah, the book, Natural Running, is where I first heard about you.
It's been a long journey. I started trying to figure out how the foot worked and how it affected running injuries in the year 2000 when I had my feet operated on. I was a competitive runner, beat myself up, and that was the first step to figure out how to heal my body. Opinion at that time was don't run anymore, but as a runner, anyone who likes to go outside, if you take that piece of your life away, sadness sets in, and that's not a good thing.
Yeah. So you are a physician. What setting were you in the 2000s?
Doing primary care. I'm a family physician, so I've seen a lot of patients in clinic, working in the hospital. Also a lot of people in the sports medicine sector as a military flight doc. So I kind of saw the full spectrum of healthy people to really, really sick people.
So why open up a shoe store?
I think it started as a community movement here, Dustin. So we started to do projects for community health here to involve trail building in schools, physical activity programs for youth. And we needed to raise money. And we started a race here called Freedom's Run. This will be the 8th year of the race. Yeah. And this race grew really, really quick. So it was the first large race in our community, and it had kids run, 5K, 10K, half marathon, and full marathon. So I didn't realize what we were getting into the first year to try to do all that at once. Yeah. I guess ignorance is sometimes a good thing to start something, but then you're like, holy cow, this is huge. Yeah. But it grew. So what I saw was new people coming out to run, and they'd be asking you about running issues, running injuries, shoes, all this stuff. And to be honest, at that point, I had already been in the world of shoe design, running research in the foot, and was running in minimal shoes, skinny shoes, kind of doing everything exactly opposite of what shoe stores and doctors were telling people. So people were asking me, gosh, where can I go to get shoes? And I honestly couldn't tell them anywhere because if you send them to the shoe store, they'll put them in a big bulky shoe with a rigid arch support, and tell them to go land on their heel. And I knew foundationally that was wrong, and that wasn't my opinion. That was all in the research and human experience of runners. So a couple local folks who were passionate about this too, James Munnis and Tom Shantz, who had helped me with Freedom's Run, and they convinced me to open up this store. And that was 6 years ago. So we opened a store, first store in the country, which only sold shoes which were level to the ground and which were flexible. So we had no traditional shoes, no elevated heel shoes, no stiff arched supportive motion control shoes. Now, that's not a fit for everybody. I mean, if people are happy in whatever shoe they're in and they're outside, that's all good. But what we wanted to do is try to retrain and reteach people how to move their bodies and get in a better shoe, not just while running, which is really a fraction of your day, but while you walk around all day. Yeah. And that's how it all started. And we had 3 brands when we opened. This was just starting. This was before Born to Run. Mm-hmm. There was Vibrams, Vivo Barefoot, and a company called Newton. That was it.
Wow. Yeah, and you're upstairs in that old apartment.
Yeah,
I remember that.
Working for us a little bit then, or I'm not sure that, or when we moved down to the larger space.
Yeah. So all types of people walk into this place, and I worked there for, I think it was 1.5 to 2 years, and it draws in a lot of runners, but we also started to get just a lot of people from the community, young and old. And I'd like to hear from your perspective, what are some of the biggest issues that older adults face that you've seen just coming into the shoe store?
Yeah, not just in the shoe store, but clinically. I work in a hospital, and I see a lot of people who have been admitted for various reasons, including falls. But balance and muscular strength and posture, that's why people fall. Mm-hmm. And if you lose that progressively over the years, your odds of falling get dramatically worse, and your odds of disease, because if you don't have balance, you don't have strength, and you don't have good posture, good movement, good body position, you don't want to walk and move because it becomes painful. And we all know that sedentary behavior triggers changes in our body, which leads to degeneration and sarcopenia, muscle wasting. So it sets up the trail of tears. So you got to have good movement and good balance to keep the engine and keep the body running. Yeah, kind of wind it up every day like a grandfather clock, so they say.
Yeah, I like that. Yeah, it's true. And I remember just for me in the store when some of these older adults would come in, of trying to fit them in a shoe that would, allow their foot to actually feel the ground, and not be too thick, but then not be too thin as well, especially if there were some sensory issues where, they, had some problems, whether they're diabetic or whatnot. From what's on the market out today, what are some really solid shoes that you feel kind of work really, really well for the older adult? I know this depends tremendously on the person, but in general, what are some of your favorites for some of your older patients?
For my older patients, my favorite is taking their shoes off completely and being barefoot, especially where it's safe, which is probably 90+% of our surfaces. So in the house, because even having a sock on your foot inhibits proprioception, which is that body's ability to unconsciously change muscle and fascia tension. So when your foot actually feels the ground, you can react quicker to any change. Say you are about to fall, your body can respond with a spinal cord reflex. So that's what I think everyone needs to do, is just get their shoe off, and be in bare feet as much as possible. For some reason, we've convinced people that it's dangerous to be in your bare feet. Yeah. Has anyone ever told you that to take a glove off and, touch things with your hand is somehow inherently dangerous? It's absurd, and it leads to atrophy. So if you get your foot strong, then the least amount of shoe possible to do whatever you need to do for that day is probably the foundational approach to proper footwear fitting. So if you're just walking around the streets, just get in some thin rubber covering. My father's had a knee and a hip replacement and had all kinds of issues, orthopedic, and he got into flat shoes about 5 years ago, and he was thinking he would need his other knee and hip replaced. And just by getting his body position better, it decreased the loads on those joints to decrease the pain enough that right now he's not thinking about getting those joints replaced. And you've rehabbed a lot of joint replacements in older patients. That's Gosh, that is huge. I mean, that is
Hmm.
just a huge process. So if we can avoid that in people, and if you're doing activity, I think, a shoe should allow you to run or walk, not enable you. So
Mm.
peeling the layers away and strengthening. So if your arches are truly collapsed and your foot is weak and you need something with a little bit of support while you're walking, sure, while you're doing that activity, that can allow you to do that. But then again, work on the cause and strengthen your foot outside of that activity. And
Yeah.
that's really just walking around in your bare foot as much as you can.
Yeah.
Wakes things up.
Yeah, that does a lot. And I think a lot of people have reservations just from some of the horror stories I hear in terms of people, changing their shoes one day, continuing the same activity that they've been doing, and then getting an injury, which is, obviously going to happen. But to see this change is a process. And for some people, it's an instant change and they're able to adapt pretty well. But some people, it can be weeks or months before they can kind of get back to, I guess, a more barefoot style of walking, or a barefoot style shoe. And
I would say
that's,
years, actually, Dustin. So
yeah,
what I
that's a good
see,
point.
and maybe you see too. So think of, I mean, even folks my age, I'm 49,
Yeah.
and they've been in a braced up shoe, squeezing their toes and supporting it since about age 3.
Hmm.
And most people I talk to have actually progressed to proficiency in minimal running. Not, we're talking about more, higher end activity. They're like, well, 5 years, 10 years before
Yeah.
they really feel confident in their movement. So first couple months kind of gets them kind of off the couch, so to speak. But I think I'm still learning stuff. I've been running in minimal shoes now for close to 15 years, barefoot for about 5.
Yeah.
There's always something new I'm learning or feeling.
Yeah, that's true. So you're definitely an agent for change in that community, just from the health and wellness perspective. And so you have the store, but then you're also doing some pretty amazing work in the hospital now. Could you tell us a little bit more about what you're up to now?
Yes, I work at a community hospital, rural hospital, variety of medical patients, and we're trying to reverse disease. So in the medical model, we're really trained in a model of treating symptoms. It's really palliative care, even what we call
Mm.
disease treatment, where it's like a mops. We have a lot of mops for blood pressure, for cholesterol, for all the different metabolic diseases,
Mhm.
but we don't turn the faucet off. So I foundationally believe that people can reverse most of their illnesses if they really apply the proper lifestyle change. Not that they're going to completely reverse all of them, but they're going to send them in the right direction. So we have a huge focus on nutritional therapy.
Mm.
The majority of people are pre-diabetic or diabetic. Many of them have no idea they even have it. And if you can get them off the simple carbohydrates, they'll start to lose weight quickly around the middle, which is what's important.
Mm-hmm.
And they'll feel better. And all of their metabolic profiles, every single thing that we're treating them for improves, including all the inflammatory conditions.
Mm.
And it's safe to try. So if you try it and it's not working for you, then forget about it. But we give them a choice. Most of the time, patients aren't offered a choice. They're told that they need to take this medicine for this problem, but not offered, well, here's your other option. Here's, option B, which is apply, a fun and enjoyable lifestyle change and see where it takes you. So we're going to actually be the first hospital that will use a paradigm called low carbohydrate as treatment.
Mm.
That's as treatment. We're not talking this is something off on the side. We'll just eat well, blah, blah, blah. This is treatment for diabetes.
Wow.
And not everyone needs to eat low carbohydrate, but the diabetics, it's the default diet. So the literature supports that for someone who has insulin resistance and glucose intolerance, reducing glucose should be your first step of dietary management, and that's treatment. And so it seems pretty simple, but for some reason, doctors, physicians and policymakers, we're all resistant to change.
Yeah.
And we want to keep persisting in things, even though they're not working. There's 50 years now of current dietary patterns and guidelines, and what have we seen? Nothing but rising obesity and diabetes rates. So continuing to persist in that mode, I think Einstein called it insanity. So
Yeah.
let's not do that.
That's true.
It puts a smile on patients' faces. You show them the foods they can eat because they were told not to eat eggs and cheese and butter and steak. And I'm in West Virginia. You tell that patient, wow, these eggs, you can go, have ham. Yes, you can have bacon. It's don't eat 50 pieces a day, but bacon is better than the bread.
Oh,
and
man.
it's 100%. They like what you're telling them, but it's a challenge. They got to get off the sugar addiction.
Yeah.
It's it takes education.
Tell us just some stories, just some patient stories in the hospital, just some of the change that you've been able to get, even within a hospital stay.
Yeah, I think the patients drive it. So, gosh, tonight we're having a community meeting, and 3 patients who were recently hospitalized are going to come share their story. One gentleman was admitted for the multitude of metabolic issues, weighed 317 pounds. Right at I think January 1 is when he came in, and he just sent me his picture yesterday. He's 50 pounds down. He has a smile on his face, and he's going to come. And, he's a pretty simple guy. He works at a local high school doing maintenance, and all I did was show him the food list. Just eat this stuff, don't eat the other stuff. Here's the list of foods. And 50 pounds down, but he got his life back. He feels good. Another patient was here a little over 6 months ago. He's going to come share his story. He's about 60 pounds down, 12 inches off his waist. Got his life back. Now he's leading church youth groups. He had no energy. His body, wake up every day and you don't think that there's a way out. I can't imagine. I feel good. I wake up every day and I want to go to work. I have energy. I want to run because my body's functioning correctly. But I can't imagine every day waking up and feeling like you're going to die.
Yeah.
And so you start sharing these stories, and then, the literature supports it. For some reason, medical literature and what happens in a hospital doesn't have the same impact as patients saying, look, this is what I did and this is working. And then you start educating. We've done lunch and learn sessions. Nurses will come in as we counsel patients and they're like, holy cow, that makes sense. Nurses will start doing it and losing weight. Pharmacists are losing weight. So it's bottom up is where is always where it starts. And then ultimately top down, instead of it one at a time, with patients that kind of believe this, whatever that means, because it's evidence-based medicine. Now we kind of look at, okay, we're going to make this a system for our entire hospital and create pathways. So we do this, with collaborative processes, pharmacy, nursing, nutrition. So I'm not going in and saying one thing, and then the nutritionist comes and says, well, eat the USDA food plate, which is 75% carbohydrates. And if you treat diabetics, just try it with a glucometer. So if someone doesn't believe me, if any of your audience is a type 2 diabetic, go ahead and eat a plate with 75% carbohydrate on it and check your sugar 1 or 2 hours afterwards. Now go eat eggs with some veggies in there, maybe a little cheese, put some butter on the pan. It'll fill you up. You won't even be hungry till dinner. And check your sugar 1 and 2 hours afterwards. And you decide what to do, because the evidence is right there with your own glucometer.
Yeah, and that's powerful. That's very powerful.
Yeah, that's what we do is check people. In a hospital, we check people before meals. If their sugar's high, we feed them sugar and inject insulin into them and store that sugar, shove that sugar into their body fat, and then they don't have energy and they're hungry again. But we feel like, okay, we made their sugar better, so we did our job, as we make them sicker.
Yeah.
I'm not afraid to say that because it's true. And we got to stop doing that. I'm trying to think of the physical therapy analogy is, okay, my patient's I don't have any falls in my hospital because we strap all the patients to the bed and don't let them move. But our fall rate in our hospital is 0. So we're doing good.
Yeah, I think the equivalent to that would be kind of in the outpatient PT realm, with some of the more active populations. A lot of times people will get rehabbed to the point where they're pain-free or symptom-free. But if you actually look at them and how they're moving and how they're performing the tasks that they want to perform, a lot of times they haven't really recovered. And so we can leave a whole lot on the table to where they go back out in the real world and they'll end up right back in our office. So there's definitely some similar lines with that. And when you were mentioning just tracking your glucometer and seeing how your food affects you, that made me think of my times in several different nursing homes, of just seeing some of these patients that have all these metabolic conditions, diabetes just being one of them, and just to see what's on their plate for breakfast, lunch, and dinner. And it was crazy just to think about. And then, their blood sugar would go through the roof, and, then they would get, X amount of units of insulin. And it's just this vicious cycle that is probably leading to more damage. And I was just thinking, man, there's got to be a better way. And I think you are definitely leading the charge to improve that situation for sure. Yeah,
there is a better way, and let the patient decide. Give them an option, And I think, Dustin, you're dealing with a lot of older folks. The next frontier is people actually understanding dementia and Alzheimer's disease, the effect of glucose metabolism and insulin resistance and diabetes on the functioning of the brain, and how when you have prediabetes and diabetes, your brain cannot utilize glucose correctly. So you go around the nursing home and all these people are eating bread and getting injected with insulin, and their brain will never work again. And, it's just a trial of things you can give the elderly. I mean, it's all over the literature, but it's not a drug, so people don't talk about it.
Yeah.
Start giving people with dementia a 1-week trial of medium chain triglycerides, because the brain can use ketones, which can be virgin coconut oil or straight up medium chain triglycerides. The brain is resistant to the glucose, and it can wake people up. There's a great website called coconutketones.com. It'll have, I don't know, it's got like 30 articles on there, patient experiences. But what do you got to lose?
Right.
If it doesn't work, you're still stuck in the chair.
Right.
But,
give them some bread and
stories, I mean, heck yeah, I told my kids, if I ever can't recognize you, here's the coconut oil. Start injecting this in my veins, and maybe if it doesn't work, it doesn't work. But at least try that before committing me to the nursing home.
Yeah. I've definitely seen more, I guess, across the interwebs of Alzheimer's dementia being referred to as type 3 diabetes.
Type 3 diabetes. Heck yeah, look it up.
Get you thinking for sure. So as rehab professionals, a lot of people listening to this are in that category. What can we do to make your life easier as a physician when in the hospital?
Yeah, I think getting up, I think the doctors need to understand what you guys are doing. So one of the other things I do on rounds is we do walking rounds when I'm on my hospital service. We have residents and students. So now what you see in hospital systems is people sit around a table, look at a computer, and round on a patient without looking at the patient. They look at the computer, they talk about it, make a plan, and then go in, and maybe the resident will go in. But without seeing the patient and being there in front of the patient and listening and looking at them, I have no idea how I can know the big issues, because what medicine you're adjusting has little difference if they can't stand up. So we actually try, I mean, there's technique in teaching people how to stand up. Hinge from the hip, use the glute. So the first thing we do when we walk in with someone is because it's fun, the patients like it, let's teach you how to stand up.
Yeah.
Then the students and the residents realize immediately what the big issue is. It's not about, okay, we need to increase their dose of lisinopril or something like that, because that has absolutely nothing to do with the patient's capacity to do activities of daily living. Can they get out of bed? Can they get out of a chair? And can we teach them how to do that? And I tell people when they can get up, I give the patients, okay, every 30 minutes, set a clock, stand up 10 times. If they're sitting in the chair, just if they're a walker, you do the same thing. It's like, it's just like training, progressive load. But if every day in the hospital, they lose 3 days of strength. So bed rest, I mean, I would flip it. And that's what therapists do, is they come in and get the patient in the chair. A hospital room is centered around the bed. But the problem is most chronic illnesses get worse by being in the bed. We have this model based in the 1800s, when hospitals were first formed, patients were sick then with tuberculosis or, whatever it is. So they actually, they were needed to be in bed, but now it's opposite. People are there for conditions that they actually need to move. So I can't fix that because it's hospital beds, but we try to get people in the chair, and we take an active role with the therapist. So we walk around and we're constantly asking the therapist, how are they doing? Give us some input. But that's how, therapists should not be afraid to talk to the doctors too, because sometimes I think whether it's a nurse or a therapist, they are intimidated by, talking to the doctor, because that, most of the things we're doing with that chronic disease, weak patient is window dressing. It's just details, because the big issue is this patient's not going to be able to go home. Taking an active role, as soon as that patient hits the door, Miss Jones is having difficulty walking, I suggest we do this, not wait till they can't walk. And then, I think hospitals should have automatic PT evaluations, because, like I was mentioning, we sit around a table and round, you don't even realize. So a patient will be in the hospital for 2 or 3 days. and the medical team may not even know that they can't get out of bed.
Mm, my
They'll say, well,
gosh.
blood pressure's good and your whatever, your infection looks better, time to go home. And then they walk in the room and they realize,
Wow.
whoa, the patient can't go home because they can't walk. And then they go to rehab and then
Yeah.
when patient, it's just money, golly.
Yeah, and
It's
there's some
years.
awesome studies that have already been published and in the works as well, just tying uh, physical therapy's role, especially in the hospital, of early mobility, frequent mobility with the patients, and how that actually saves money and improves
Yeah.
outcomes. And I hope that shift continues to go more in favor of getting patients up and moving. And it's very encouraging to hear a physician like you be so supportive of physical therapists, because that's not necessarily the norm in the acute care setting.
And it may not even take a true physical therapist to do, I think it's like a vital sign. What do you eat and you move? So you may have a physical therapy assistant, like a vital sign.
Yeah.
Patient comes in the room, and can they move? Check, okay, they can't do that. And then you put them into this protocol, need to see the therapist.
Yeah. There's a PT down in Georgia. She's a guest on this podcast, Rachel Walton Mao, and she started a mobility program in her hospital. She's down in Atlanta, and it was a nurse-driven mobility program. And so the nurses would get the patients up and walk them, I forget the frequency, every half hour that they were awake, something along those lines, and just tracked their fall rates. And I'm probably going to misquote her, but they had a 50% reduction over the first year of this program.
That's not like small risk reduction. That's
yeah. And it's something so simple, and granted, I know, everyone in the hospital seems to be stretched pretty thin, but yeah, if we can just really value the very simple form of ambulation, that's a super powerful thing for our patients. For sure. So
walking is food, if you're, as long as you don't have a disability where you can't walk, but for most of us, it's weakness.
Yeah.
We don't have a spinal cord injury or, those issues, which are different.
Yeah. So you mentioned, you're gaining a lot of momentum in that community, and it was really a grassroots effort. When did you really start to implement nutrition into your care? How long ago was that?
Probably about 5 years ago when I started to understand about nutrition. I think I was offering nutritional advice, which was all wrong until about 5 years ago.
Mm-hmm.
I was a runner and I really believed everything we taught because it seemed to work for me. Body had one compartment. We eat food, we burn food, so that was, if you needed to lose weight, you needed to be in a calorie deficit, so just burn more. If you're gaining weight, it's because you have some foundational character flaw, you're lazy and you're gluttonous and you need to get moving.
Yeah.
And then I worked for a project on the Air Force dealing with fitness test failures and programs to help people pass the fitness test. In the military, you lose your job. And I quickly realized most of these people were motivated. They were exercising, but when they had a high body mass index, their failure rates went up. So I came randomly across an article. I don't know how, I just start searching stuff. And I pulled up this article by Gary Taubes in 2002. The article was from 2002, New York Times. It was called "Maybe It's All Been a Big Fat Lie." I read this article and I read it like 3 times. And I'm like, this is right. This is what I've witnessed for 15 years of medicine. At that time, I've been practicing 15 years. And that led to, I was on a 6-month sabbatical to do this project. And that led to like 2 months of, I have, probably about 100 books in my basement on nutrition and history of nutrition. And everything I read confirmed what Taubes was saying.
Yeah.
That there was this alternate hypothesis, which was insulin resistance. So obesity is not driven by some character weakness. If you're insulin resistant, by design, your body is triggered to store, which makes you hungry and makes you not want to move. So, and that's driven by the food environment. So if you're prone to insulin resistance, which is the majority of us, and you start eating simple carbohydrates, you will be driven to store. And this was happening to me too, even as a runner. I was eating 24/7 cereal. I would wake up at 2 in the morning because my body was constantly trying to get energy from this glucose. I couldn't use fat, and I was just chasing carbohydrates, massive amounts, and there was no way to live. And actually, my lipid parameters were bad. Everyone in my family has metabolic disease, so I was heading in that direction. And then I did my own experiment. That was my last bowl of cereal, so I started going back to I realized quickly after reading the literature that there was no harm in eggs and there was no harm in cholesterol. There's never any study that really showed this. It was flawed.
Yeah.
So I did my own experiment. And then I started doing this with patients. If you're diabetic, stop sugar. And one at a time, the ones that did it would lose the weight. And now it's becoming larger scale. We have a community group that's meeting tonight. We'll have about 250 people in the room learning about this.
Wow. That's amazing to see, because before I moved away from Shepherdstown, from the Panhandle, I think you had your first nutrition meeting at the local hospital. And I mean, there was a pretty good showing there, but just to see how much this has grown just in the few years that you've just been getting after it. What would you say to people like me, rehab professionals that want to get on board with what you're doing, that may not be in the area, but what would be your advice for someone that's wanting to make a change for some of these patients that are trying hard, they're doing everything that they're told but not getting results, and a lot of it could be stemming from that nutritional aspect?
I think everyone's different, so there's not one suit for every person. So they have to understand a little bit about their metabolism.
Yeah.
And they need some guidance and they need support. So the people that succeed, so if you're at home and you're a mom and you're 40 years old and you already have type 2 diabetes, you're 50 pounds overweight, and you're on SNAP and you don't know how to cook and prepare healthy food, you don't even know what it is, and everyone in your family's bringing home Mountain Dew, it's going to be really hard for you to say, I'm going to get rid of all that crap, because those foods are addictive. So the people that succeed is, so in the hospital, if the wife is the one who cooks and the husband's in the hospital, I make sure the wife's in the room, and they'll go forward together. So they need support and they need some knowledge and they need a simple food list, and they need to be given permission just to try it, because for someone who's on carbohydrates and you stop the carbohydrates, their body is used to using sugar as fuel. They can't yet use fat as fuel. It's locked in. And it's going to take about 3 to 7 up to 14 days for those insulin levels to drop, glucagon to kick in and mobilize fat. Now, for someone who's been diabetic for 20 years, it's going to take even longer than that to really reverse those processes. So based on the individual, you need to give them guidance, give them patience, follow them. Like I give people my email and text, and it's great because I love the emails, of, wow, I mean, someone sends you a picture and here's their pre and post.
Yeah,
You're like,
man.
Yeah, and it takes 2 seconds. I think we're in the virtual world now. So, I mean, if these people had to call a clinic, wait on hold, if they have an immediate question and come in 3 weeks, that's our first appointment with your doctor, and they get 3 minutes with that doctor, they need support, and they need community level support. They need people giving them all a similar message until it works or it doesn't work, but get them over the hump.
Yeah. Real quick, could you tell us about the future of this program and kind of what you're planning on building there?
Yeah, so we're actually hoping we have some visitors coming from California. So there's a pilot disease reversal clinic now in Purdue with Dr. Sarah Hallberg, and you could watch it, maybe link it on the show notes. There's a awesome TED Talk by Dr. Hallberg called Reversing Diabetes is all about ignoring the guidelines. And Sarah, she's brilliant. She's a lipidologist, obesity specialist. She's triple boarded, internal med doc, seeing thousands of patients in her clinic. And she has the first clinic now with the goal of reversing disease and is doing the hard research there. So she's the first clinic, and we're going to open a second pilot clinic to do this project. So we want to prove what we know to be true by patient experience. So let's get more numbers, scale it up. So I'm hoping that'll be up by summer. So if a patient has diabetes and they actually are interested in reversing it, come here and we're going to help, and we're going to work with your doctor. So it's not like we're going to take over care of people. So we want to help patients. I mean, they all have awesome doctors who care about them, but this is just like a niche thing, just like if you had a bad knee and you needed to see a PT. So we would be a referral for that specific condition, work with them on their medications, give them the support, help them get off of their medicines. The money savings of this is incalculable. If you look at the chronic disease care, we can't afford this for our future. I mean, there's no way. It's impossible. So we've got to figure this out, or my kids, if you have a family someday, it will not work. There will be nothing left for them.
Yeah.
It's breaking the bank.
Yeah.
So that's the goal, is reverse make people healthy and save, billions of dollars along the way. Every diabetic costs their health insurance plan $20,000 a year. And the older patients ask any of your patients who are on Medicare what their copay is for their insulin. That's motivation right there. Yeah. Serious. It's like, if that's their motivation, how much do you spend on insulin and these newer fancy diabetes meds? It's like $500 a month out of their pocket.
Gosh.
I'm pretty psyched if I were, and these people are on Social Security.
Yeah.
Heck yeah, they can go buy tomatoes.
And some butter.
Fresh bacon.
Yeah. That's awesome. All right, well, let's wrap things up. One more question. If you had every rehab professional in one room that worked with the geriatric population, what would you want them to know?
I think, probably a lot of the things you're talking about on your show. Get patients out of bed and teach them balance. Figure out their restrictions. So what's inhibiting them from, because you know how it is. If you can't get up without fear, you're not going to get up. So everyone has a unique issue, just like with nutrition. What's the elephant in the room for that patient that's inhibiting them from living like a normal, biologically well person?
Yeah.
So they need someone to look at the body head to toe.
Yes.
Fix the deficit, not treat the symptom.
Boom. I love it, Dr. Mark.
No, my pleasure, Dustin.
I appreciate your time, and you're a very motivating individual. You have been for me, ever since I met you. It all started with the shoe store and just really getting a whole community thinking differently about how they're running, how they're walking, how they're moving, and now you just keep taking it to the next level. And now from the nutritional aspect. So keep doing what you're doing. I'm always going to be here to support you. I know many people listening to this are going to be very interested in supporting you as well. So if people do want to learn more about you and what you're doing, where could they find you on the internet?
I have a website called naturalrunningscenter.com and sports med, running issues, but also we get into nutritional issues. TwoRiversTreads.com if you want to learn about footwear, the foot, running form, all the biomechanics of running. Go to that site, TwoRiversTreads.com. We've got some great videos up there. So those would probably be the first two places to start, just to get some background on the things we're doing here and things that you could share out with other people.
Okay. And those will be linked to the show notes along with the TED Talk as well. And I'll look up that Gary Taubes article that you came across in 2012. So, all right, Dr. Mark, I appreciate your time.
Okay.
Hit me. Thank you for listening to the Senior Rehab Podcast. The show notes for this episode and much, much more can be found at seniorrehabproject.com. If you found value in this conversation, please share this with one other person that could benefit. And until next time, do not forget to stay funky.